Hello, Clinic Review family. It's Dr. Sharon, and we are going to be talking about amputation today. You can find that information in the Blue Book. Remember, the Blue Book is facts that you need to know. I write questions to apply them and how you can use them in questions. I worked with amputees for several years back in my younger years, and so this is sort of a fun thing to teach about, and it's not super intuitive, so I do think you'll find it interesting and helpful. So let's go ahead and get started. Hello, Clinic Review family. It's Dr. Sharon with Clinic Reviews. I'm very excited to talk with you about amputations. I'm actually adding to some of the content in the Blue Book. The Blue Book generally talks about amputations and the care for an amputee after kind of in the immediate post-op period. I'm going to be talking about more about prosthetics as well, and fitting for prosthetics and how you could get questions about that and what the nursing role is in that. So you know that we're the YouTube channel is a part of the greater Clinic Review organization. We do offer the best NCLEX review in the entire universe, in my opinion. You can go to clinicreviews.com. It's primarily offered as a streaming service. Every once in a while, Mark Clinic still does in-person reviews, primarily in the summer months, May through August, kind of when the demand is higher. And we also offer small group tutoring. It's a monthly block of tutoring that you purchase. You can get that at clinicreviews.com. We also streaming. If you're taking your NCLEX soon and you want to get all of our videos, not the NCLEX prep videos, but the videos you get here on YouTube, as well as some additional videos. If you want to get those all kind of in a big block, you don't want to wait, you don't want any commercials, you may want to do our streaming service, and I'll make sure that that link is in the description below. Okay. All right, let's go ahead and get started with questions. When providing care for a client with a recent below the knee amputation, what is the priority nursing action? So I want to make sure that you know what BKA stands for. BKA is below the knee amputation. That's when the amputation is below the knee. So they still have their knee joint and they can still move their knee joint, and the bottom, the lower half of the leg can be flexed and extended. And then there's above the knee amputation. That can be anywhere from just below the hip joint to just above the knee. So it really depends on how much of a limb they have left. The amount of limb that they have left determines whether they can have a prosthesis or a typical prosthesis. So prosthetics are attached by suction. So it's not really strapped on so much. I mean, there's some strapping involved, but it's mostly just suction, and they put kind of a sock like thing around the stump, and then they sort of put the prosthetic on sort of by suction. It goes and it stays on that way. So it has to be fit perfectly, y'all. If it doesn't fit perfectly, it's going to rub badly. They're going to have skin breakdown. So it's really important that happen. So when providing care for a client with a recent below the knee amputation, what is the priority nursing action? My immediately mind goes to reduce swelling. That's one of the things I want to see happen. And I want to prevent contractures, because if they end up with a contracture of their knee or their hip, they're never going to be able to fit a prosthetic. So that's where my mind goes before I even read the answers. So let's read the answers and see what they have. Inspect the incision for signs of infection. Well, we do want to do that. Begin prosthetic training on the second post-op day. That's false. We don't do prosthetic training until the swelling is gone. If we fit for a prosthetic before the swelling is gone, then once the swelling is gone, the prosthetic's just going to fall off, because remember, it's fitted perfectly for and kind of a suction type thing to keep it on. So we actually don't fit for the permanent prosthesis for months afterwards. It takes a long time for all of the swelling to go away. So B is absolutely not true. C, massage the residual limb to promote healing. We can massage the residual limb, but it doesn't promote healing. That's not why we do it. We do it to prepare for the prosthesis, to try to toughen the skin up. So that's not really important if they just had a below the knee amputation, that's not that important. Avoid range of motion exercises to prevent pain. Well, we don't do that anytime. We like range of motion exercises. So even though the answer I was looking for isn't here, the only one that makes any sense is A, because I'm not going to do any of the others. And remember, the right answer is the right answer because of the other answers, y'all. Whether the answer you're looking for is there or not, look at the answers and say, what are they really testing on here? So I wish it would have said, when providing care for a client in the immediate post-op period, what's important or what's the priority nursing action. I wish it said that. That would have been more clear to me, because I would have said, oh yeah, I got to watch for signs and symptoms of infection in the immediate post-op period. It said recent. Recent to me doesn't always mean immediate post-op period, but it doesn't matter because none of the other answers are true. So I pick the answer that is most true based on the way the question is worded. I want to make sure it is appropriate for the question that's being asked. And I also can rule out other answers. A client who had a below the knee amputation reports experiencing tingling and itching in the missing limb. The nurse recognizes this as which of the following? So that's actually very common. And what it's called is phantom limb pain or phantom limb sensation. And what happens is, this is why do we still do amputations in, well, this is 2024. If you're watching it in 2025 or 2026, why are we still doing amputations in the mid 2020s, right? That can't we heal these legs? And we can't always, if they have poor circulation to their extremities, we can try to restore circulation, but we can't always do that. And sometimes the pain is so severe that they just can't live with it anymore. So we have to amputate it. Sometimes the infection is so severe where they're going to go septic, that kind of thing. That's why we still amputate limbs, right? To either quality of life or to save their life. But by the time they get to the point of amputation, they've been having the pain for so long, and the nerves in the leg that have been sending those sensations to the brain have been stimulated so much and so often that they continue to send those pain signals up to the brain. And sometimes it's just numbness and tingling, but whether it's numbness and tingling or actual pain, those sensations have been traveling along those nerves for so many years that it actually continues to send those pain sensations to the brain, even when the leg is gone. So eventually the nerves stop sending the signals. It does eventually happen, but sometimes the pain in the phantom limb is almost as bad after surgery as it was before, just because those nerves have kept sending that sensation. So don't ignore phantom limb pain. It's not, when I say it's not all in their head, I guess it is all in their head. It's all in their nerves in their head, but it's legitimate pain. They actually feel it. We don't ignore it. We treat it just like we treat any other pain. Now, often we treat it with like a Neurontin, which is gabapentin. That's for peripheral neuropathy because it calms down those nerves. So sometimes that's how we treat it. And sometimes we treat it with actual pain medication. It doesn't have to be an opioid necessarily, but other types of pain medication that we might be able to use. So we do treat it just like any other type of pain. And then over sometimes years, it takes for that pain to actually go away. The nurse is teaching a client how to wrap the residual limb after an above the knee amputation. Which instruction should the nurse give? So this is an above the knee. It doesn't tell me where. It could be anywhere just above the knee all the way up to the hip. And they're hard to wrap. They're harder to wrap than a below the knee amputation because there's not a lot for the dressing to hold on to. So you do have to wrap it kind of specifically. So wrap the stump with an elastic bandage in a circular motion. I mean, that's okay, but it's likely going to fall off if you do that. Apply the bandage tightly to reduce swelling. So we don't want to wrap anything tightly because it can cut off circulation. I don't want to do that. Wrap the stump using a figure 8 technique starting at the distal end. That's the way you prevent it from falling off. And you always start distally. Otherwise, you can inadvertently cut off circulation. So you always start distally and you wrap it in a figure 8. And this will help it stay on, okay, especially in above the knee amputation. Avoid using any dressing until the surgical incision heals. That's not true. We do wrap it, and we wrap it to start to reduce the swelling in the extremity. A nurse is caring for a client after a BKA. So we're below the knee. These are a little easier to care for, a little easier to fit for prosthetics, a little easier to wrap. Which of the following actions should the nurse take to prevent edema in the residual limb? Elevate the residual limb on pillows for the first 12 to 24 hours. Okay. Apply a warm compress to the residual limb. Y'all, this is about preventing edema, right? Prevent edema. A warm compress is going to promote edema. It's going to pull all that fluid into that limb. It's going to just swell up. Keep the residual limb dependent. No, that's going to cause more swelling. Encourage early ambulation without a prosthetic. No. I mean, they can ambulate without a prosthetic, but it's not going to prevent edema. So no, that's not going to help it. So the only one that makes any sense, and the only one that we know is a common intervention for swelling, is elevation, right? Now, the reason we have a time limit on that is because we do not want contractures to occur. The biggest complication after, more of a long-term complication after any amputation is contracture. For whatever reason, they have patients who've had an AKA have a tendency to flex their leg up, and it can get stuck that way, contracted. They tend to flex their leg down. It's a knee at the knee, and that can get contracted. And so we want to prevent that. So we don't generally elevate on a pillow, but in the first 12, as long as we have a time limit there, the first 12 to 24 hours is okay in order to prevent swelling. A client with an AKA is at risk for hip contractures. True. Which intervention should the nurse include in the plan of care to prevent contractures? So it is the hip contracture that an AKA is at risk for. So what are we going to do? Place the client in a semi-Fowler's position. Well, a semi-Fowler's position contracts the hip, so that's not good. Encourage the client to sit in a chair for long periods of time. If they're sitting, they're contracting their hip joint. No, that's not a good idea. Instruct the client to lie prone for 30 minutes. They're laying on their stomach. And when you lay on your stomach, you almost have to have your hip extended, the hip joint extended. So that's a good idea. Use a pillow under the residual limb while the client is in bed. Again, you're flexing the hip. So no, that's not what we want to do. So this dog does not usually, come here, Cook. Come here, buddy. This dog does not usually come to see me while I'm recording. So this is my big Newfoundland. If you've ever had a Newfoundland, y'all, they're huge. And they're lovey-dovey dogs, but they shed a lot, right? You don't usually come to see me when I'm recording. Good boy. So laying prone is actually not real intuitive, but that's a great way to prevent contractures. And now my other dog, Israel, wants attention because Kodak is getting attention. And Kodak is nibbling on Israel's ear. That's actually an affectionate gesture. Okay, a nurse is caring for a client who recently underwent a BKA and reports experiencing phantom limb pain. Which defying intervention should the nurse implement? Well, I don't want to ignore it. That's one of the things, okay? I don't want to ignore it. Apply a cold compress to the residual limb. Well, that's not usually what we do for pain. We do that to treat swelling, but not usually pain. Encourage the client to tough it out as the pain will eventually resolve. No, because that's just ignoring it. Recommend the client avoid physical therapy. No, because physical therapy is really important actually after an amputation. Administer prescribed analgesics as ordered. Absolutely. We treat it like we would any other pain. Now, it doesn't have to be an opioid. It could be, gabapentin for the neuropathic pain, but either way, we can give whatever is ordered. A nurse is educating a client on stump care following an above-the-knee amputation, which statement by the client indicates the need for further teaching. Now, y'all, I always get confused with these further teaching things. Further means false. I always forget which one I'm looking for. So I'm looking for the false statement. I'm going to say it 3 times so I don't forget. False statement, false statement, false statement. Okay. False statement as it pertains to stump care for the AKA. I will wash my stump daily with mild soap and water. Well, that's true. That's good to do. I should apply lotion to my stump to keep the skin soft. I don't love that answer because we don't usually tell people to put lotion over an incision. So I don't love it. I need to avoid sitting in one position for too long. Well, that's true because it's an AKA. And we don't want them to flex their hip too much. I should report any redness or swelling to my healthcare provider. Well, that's true as well. So I know A, C, and D are all true statements. So even though I wasn't completely sure about B, I was like, I don't like it, but I'm not sure. I'm going to pick it because the other answers are all clearly true. So y'all, this is a legitimate way to answer questions. Part of the reason I go through questions with you is so that you can see how I think and you can see how to answer NCLEX questions. When you get done with your NCLEX, you're not going to be going, oh, I know I passed. I just know I passed. I mean, you might, I guess, but that's more of the exception than the rule. Usually you get done going, I don't know how I did. I mean, I don't know. I'm not sure. That's typical because these are clinical reasoning questions. There's not always an obvious right answer. You have to use clinical reasoning. And that's why I want you to see me using clinical reasoning. After a BKA, what is the most important position to avoid to prevent knee flexion contractures? Okay, BKA, I want to avoid contractures, supine with a pillow under the knee. Well, that's going to cause knee flexion, and I don't want to do that. So that's not good. Prone with the residual limb straight, that's okay. They can do that. Sitting in a chair with legs extended, that's okay. That's straight, supine with legs flat on the bed. Those are all okay because we want straight, right? We don't want the knee flexed. So the only one where the knee is flexed here is A, and so they would want to avoid that. A nurse is preparing to educate a client with a BKA about prosthesis fitting. What should the nurse emphasize regarding the preparation for prosthesis? Okay, prep for prosthesis. Okay, BKA. You can be fitted for a prosthesis as soon as your incision heals. That's false. We don't do that. We do it when the swelling is gone. It is important to begin weight-bearing exercises immediately. That's not true. Not immediately. You can begin them, but it doesn't have to be immediately. You will be fitted with a prosthesis once your residual limb is fully healed and the swelling subsides. Good, I like that one. You must remain on bed rest until you're fitted with a prosthesis. That's false. So C is the only right answer here. A client with a below-the-knee prosthesis reports discomfort and redness at the site where the prosthesis makes contact with the residual limb. What should the nurse recommend? Y'all, if they're having discomfort and redness, it is not fitted correctly. The prosthetic does not fit correctly if they're having redness and discomfort. And it's not going to get any better however long they wear it. The big risk with prosthetics is skin breakdown, because if it's not, it has to be fitted perfectly. If it's not fitted perfectly, they're going to rub skin raw and they're going to have skin breakdown. So the only way to fix that is to get it fitted, refitted, to have somebody look at it to see how they can correct the fit. Continue wearing the prosthesis to allow the skin to adjust? No, that's not going to help. Apply lotion to the residual limb? That's not going to help poor fitting. Tighten the prosthetic straps? That's not going to help poor fitting. Stop wearing the prosthesis and consult the prosthetist for adjustment. That's the only option that they have if it's not fit correctly. The nurse is educating a client on the care of their prosthesis. Which of the following statements by the client indicates the need for further teaching? Okay, further teaching as a result to care of their prosthesis. Further teaching, which is false. I will wear the prosthesis continually, even if it feels uncomfortable. That's false. If it's uncomfortable, it's not fitting correctly. Well, it may not be not fitting correctly if it's just uncomfortable, but if it's painful or rubbing, you definitely not fit correctly. But you don't have to wear it continuously if it's uncomfortable. I should clean the inside of the prosthetic socket daily. Yeah, that's fine. I need to inspect my skin daily. Absolutely. I will gradually increase the amount of time I wear the prosthesis each day. Absolutely. That's true. So this is the care of their prosthesis. A is not really about the care of their prosthesis, I guess, but it's the only answer that makes any sense, because B, C, and D are all true. And the only one that requires further teaching is A. During early prosthetic training, which intervention is most appropriate to assist the client in adapting to the prosthesis? So I don't know if it means physical adaptation or emotional adaptation. It's not clear to me with the question. So I'm going to read the answers and see. Limit weight-bearing activities until complete healing has occurred. Push the stump against the wall several times a day to toughen the stump. Suggest using the prosthesis only during physical therapy sessions. Encourage the client to avoid using assistive devices like crutches or canes. So it looks like they're talking about physical adaptation. All right. Which intervention is most appropriate to help them adapt? Limit weight-bearing activities until complete healing has occurred. That's a weird answer. I don't know what that means. Complete healing? Because we wouldn't be fitting the prosthetic if complete healing hadn't occurred. So A just doesn't make any sense to me. I mean, the only way I'll pick that is if absolutely everything is totally wrong, because A is just a weird answer. Push the stump against the wall several times a day to toughen the stump. Actually, that's a good idea. They need to toughen the stump. So it's just like your feet, the bottom of your feet or the palms of your hands. The skin is much tougher on those places because there's a lot of pressure put on those places. You develop calluses where you put a lot of rubbing or pressure on. And you have to do the same to the stump. The stump is going to have to be toughened up because it's going to be attached to this prosthetic and you're going to be putting weight on it all the time. So it has to be toughened up. And one of the ways you can do that is to push it against the wall several times a day. Start toughening it up. You can massage it. If it said massage it, that would be another appropriate answer. But you got to start toughening that stump up. So that's appropriate. Suggest using the prosthesis only during physical therapy sessions. No, that's not appropriate. Encourage the client to avoid using assistive devices. Well, no, you can use an assistive device if you want to. So the only answer that makes sense is B. A client is having difficulty adjusting to life with a new prosthesis. What is the nurse's priority action? Okay, again, I don't know if this is emotional or physical adjustment. Encourage the client to speak with a support group of amputees. Suggest the client avoids using the prosthesis until they feel comfortable. Recommend the client see a psychiatrist for long-term therapy or provide minimal emotional support as the client needs to become independent. So it looks like this is an emotional adaptation or adjustment that we're talking about. So this is a therapeutic communication or a psych question wrapped up in a med-surg setting. And a lot of people say, I don't know how to answer these questions, Dr. Sharon. When it's a psych question like this, how do I know what the right answer is? If it's a therapeutic communication or a psych question wrapped up in a med-surg setting, you want to encourage them to express their feelings. The client is having difficulty adjusting to life. So I say, I want to know how you're feeling. Tell me more. Let's talk about it. So I'm looking for an answer that says, tell me more. Let's talk about it. Encourage the client to speak with support group of amputees. That's talking about it. That's fine. I don't love it because I would rather do something immediately than put it off. But if there's no immediate option to talk about it, then that's a good answer. Suggest the client avoids using the prosthesis until they feel comfortable. That's a bad option. No. Recommend the client see a psychiatrist for long-term therapy. Maybe. Provide minimal emotional support as the client needs to become independent. That's bad. Okay. D and B are out. So there's no option for me to say, hey, tell me more about how you're feeling. If there was an option to say, tell me more about how you're feeling, I would pick that. But that's not there. Remember, the right answer is the right answer because of the other answers. So the one I was looking for isn't here. So do I want to encourage the client to speak with a support group of amputees or recommend they see a psychiatrist for long-term therapy? If you don't know this, psychiatrists do not provide talk therapy. Psychologists provide talk therapy. Psychiatrists prescribe medication. So when it says psychiatrist for long-term therapy, that means get them on some medication. And that's not what they need to do. They need to talk about it. So the only option there that shows I know that is A. All right. Okay. Well, I hope you found that helpful. I probably talked a little more than I usually do because I have clinically cared for patients with amputations in the past. And so I thought a lot about that and enjoyed talking about it. Thank you for watching to the end. I hope you got to see my doggos because I love my doggos. Two of them were not, they're in the room with me, but they didn't come up to the camera. So anyway, thank you for watching to the end. I hope you have a great rest of your day. Bye.